Hello again. All right, so we're going to continue talking about the female reproductive system, and we're going to focus on the hormones that are involved in the ovarian cycle in this particular talk. So remember, in the female, you have the ovaries and you have the uterus, and there's two different cycles. There's the cycle going on in the ovary where you have the maturation of the follicles and the ova or the oocyte. And then you have the thickening and thinning of the uterus. That's the uterine cycle. So that's going to be a separate talk. So this particular talk is just the ovarian cycle and the hormones responsible for that. Okay? Trying to break this down into manageable pieces. Okay, so when we talk about the ovarian cycle, we're really talking about a certain set of hormones. I want to tell you which hormones to be focusing on. And the first one is GnRH. That's that gonadotropin releasing hormone. So I want to see, do you remember where that's from? The hypothalamus. Okay. Your gonadotropins, FSH and LH, follicle stimulating hormone and luteinizing hormone, from the pituitary, anterior, posterior. I told you had to remember this. Anterior. Okay. The ovary makes estrogen and progesterone. And then a final hormone called leptin. All right. And there's one more, actually, inhibin, and I should have written this one in as well. So leptin from adipose tissue, and then inhibin also in the ovary. I just realized I'd forgotten one. So those are really the hormones that we're going to focus on in the ovarian cycle. Okay. So during childhood, your ovaries are growing, and they are secreting some estrogen, very small amounts, but it's enough to inhibit the hypothalamus from releasing GnRH. Okay, so as you're growing, getting older and bigger, everything's getting bigger. Your ovaries are starting to mature, but they're not. You're not becoming cyclical. You're not having a period yet. As you reach puberty, leptin levels are going to increase, and if they're adequate, that's going to cause the hypothalamus to be less sensitive to that estrogen. Okay, and therefore the GnRH can now be released, and that's going to cause FSH and LH released. That's going to travel to the hormones and the ovaries, and cause ovarian hormones to be released. Now, I want to say something about leptin and adipose tissue. That's one of the thoughts that maybe we're still looking at, that is possibly why girls in the U.S. Maybe have they reach puberty earlier. It's because better nutrition, childhood obesity, some more adipose tissue. So we are wondering if maybe that's a correlation, the amount of nutrition and childhood obesity raising our adipose tissue levels and possibly leptin levels, maybe pushing the puberty at a younger and younger age. What we do know, as the leptin levels are increasing and the hypothalamus is becoming less sensitive to estrogen, this GnRH is being released. It's released in a pulse-like manner. Okay, so you think in that cycle, it's going to start being cyclical. But it takes about 4 years for this to become kind of regular. So those gonadotropin levels are going to increase for about 4 years before you have ovulations, and then therefore you can't get pregnant without ovulation. So after about 4 years, you're finally going to have the first period. Okay, you're going to have the adult cycle or cyclic pattern is going to be achieved. The first menarche or first menstrual period will occur. So again, it takes about 4 years for this to happen. So if your first period is at 14, sometime around 10 years old, you should have started seeing more axillary hair, breast buds, all those things that we think about as you're going through puberty. But you're probably not ovulating. Now, once you've had your first period, it still takes another 3 years for that to become normal. So it's not unusual. It's very common for a girl to have a period and then maybe go a couple of months, have another period, maybe have 2 or 3 in a row, and then go a couple of months. It can take about 3 years for this to become regular, and also for every cycle to become ovulatory. So every cycle when you first start your period doesn't necessarily mean you're going to ovulate an egg. However, you could. Okay, so a girl who's had her first period, you can assume she could be fertile. So you never know. Everybody's a little bit different. So once a female has had her first period, it is possible that she could have ovulated and could ovulate every time. So you have to be really careful when you're talking about sex education and birth control. Even before that first menarche, you may not know that the girl may have ovulated the very first time. So having intercourse prior to that first menarche could result in a pregnancy. There have been, children, girls who have become pregnant before they've ever had a period. and that may be why. So you always have to assume with females, once they reach stages of 8 to 12, and they're in that puberty period, they could possibly be fertile. So once this cycle becomes cyclic, it's about a 28-day cycle. And so there's the interplay of gonadotropin causing the release, or GnRH, sorry, gonadotropin releasing hormone, causing the release of FSH and LH. This FSH and LH is going to target the ovaries and cause some of the follicles to grow. That's going to cause some hormones to be released. All right, you're going to get an increase in the amount of plasma estrogen, which is going to have a negative feedback effect on FSH. If you have a high level of estrogen, that's actually going to have a positive feedback effect. All right, and then there's that inhibit we talked about. It's going to play a role in negative feedback. So that was probably really confusing, because I really want to talk to you about it as I show you this picture. I should have just kind of waited. I wrote it all out for you. Now I'm going to talk about it. So I apologize for that. Sometimes I get to talking and forget to change the picture. So let's say what I just said as we're looking at the picture. All right. So your hypothalamus releases GnRH. Okay, that GnRH travels to the anterior pituitary, causing the release of FSH and LH. Okay, that's, if you go back to here, this is step 1. All right. Step 2, FSH and LH are hormones. They travel in the blood to their target, which is the ovary. Okay. The FSH is going to target the granulosa cells. The LH is going to target the thecal cells, and these are both associated with the follicle. All right. The granulosa cells are going to make estrogen. The thecal cells are going to release androgens. Now, these androgens stay in the area, and the granulosa cells will convert those androgens to estrogens. So the effect basically is you're going to get an increased level in estrogen levels. And so now estrogen levels are going to start to rise in the blood. Okay, so you're going to get an increased level of estrogens. All right. The granulosa cells also make something called inhibin. And so rising levels of estrogen, so as these estrogen levels are rising and this inhibin levels are rising, they negatively feed back to the anterior pituitary and the hypothalamus, shutting that cycle down. So it's kind of a negative feedback system. All right. The estrogens also work kind of like a paracrine, kind of in the area, to help mature those follicles. All right. So we're causing this follicle to mature and become a mature follicle. All right. So the next steps, 4 and 5, we're going to have a kind of a brief high level of estrogen levels. And estrogen levels are going to go so high that they actually cause a positive feedback on the brain. All right, I'm going to show you that in the picture. And this is going to cause a sudden release, mainly of LH, some FSH. This is the trigger for ovulation. It's also the trigger for the oocyte to complete meiosis. Okay, so let's look at the picture. All right, so again, we have our GnRH causing the release of FSH and LH going to the ovary, causing the ovary, the thecal cells and granulosa cells to have an increased level of estrogen production. That estrogen is going to cause the maturation of the follicle. Now, once, for a brief period, when that estrogen level is so high, it actually goes back and positively feeds back on the hypothalamus and the anterior pituitary. And it causes an LH surge. So you get a really large release of luteinizing hormone. That's the trigger for ovulation. Okay? And again, this also causes the primary oocyte to complete meiosis 1 to become a secondary oocyte. Okay? And now it's going to begin meiosis 2. So go back to oogenesis. That way you can remember what's going on with the oocyte development. Now, once you've had the LH surge and you've had ovulation, so that's just a brief period. It doesn't last days. It's like just like 1 day's ovulation. It's kind of a quick event. Once you've ovulated that egg or released the egg, your estrogen levels will now decline, and that luteinizing hormone will turn that follicle into something called a corpus luteum. So it's luteinizing hormone, corpus luteum, that's how you put your names together. And the corpus luteum now becomes a hormone producer. All right, it's going to make progesterone and estrogen. All right, now what the corpus luteum's job is to produce these hormones, because progesterone, if there is a pregnancy, it will help maintain the lining of the uterus so that the fertilized egg has time to travel to the uterus and implant. So that progesterone helps keep the uterus, gets the uterus ready for pregnancy. It will also maintain the pregnancy if a pregnancy occurs, because it takes a while. You need the placenta as part of it's a hormone producer during pregnancy, but until you have a placenta, the corpus luteum kind of plays that role by making progesterone. And we'll talk about that as we move into the uterine cycle and pregnancy. Now, the last part is you have negative feedback. These rising progesterone and estrogen levels that you're having from the corpus luteum is going to inhibit FSH and LH release. Okay, the inhibin from the corpus luteum and granulosa cells will enhance that effect. All right, so let's go and put all this together. This is a really complex slide. It's in your textbook, along with some nice text that goes along with it if you want to read along with your textbook and look at the text with that. So GnRH causes the release of FSH and LH. They target the ovary, the thecal cells, the granulosa cells. You get an increase in estrogen. You also get inhibin. Those work to act as negative feedback mechanisms. Once estrogen levels increase high enough, they exert a positive feedback mechanism, causing an LH surge. The LH surge causes ovulation, and also the movement of, or the progression of the egg through meiosis 1 into meiosis 2 to become a secondary oocyte. And that secondary oocyte is then released into the peritoneal cavity, and hopefully the fimbriae of the uterine tube will catch it and possibly be fertilized. All right, so we're going to have to figure out what happens to that egg and sperm as we move into pregnancy. We haven't gotten that far yet. In the meantime, we don't know what's going to happen to that egg, but the follicle turns into a corpus luteum. And again, that corpus luteum is going to make progesterone, estrogens, and inhibin, and that's going to feed back negatively to the hypothalamus and the anterior pituitary to shut the cycle down. We don't want to be ovulating anymore. We want to give the body a break, see what's going to happen, see if we're going to get a pregnancy. Okay, so we're going to kind of inhibit the hypothalamus from producing GnRH, FSH, and LH from the anterior pituitary, and give that possible oocyte a chance to be fertilized and become a baby. Okay? Now, if there's no fertilization, if nothing happens, that corpus luteum will degenerate as those LH levels fall. You're also going to get a sharp decrease in estrogen levels and progesterone levels. That's going to stop that negative feedback inhibition. So that's going to end that blockage of LH and FSH, and the cycle starts over. All right, so if no fertilization, you just progress right into the next cycle. If there is fertilization, you keep it blocked so that you can allow that oocyte to get into the uterus and possibly develop and form a placenta and then a healthy baby. So we're going to get into all those details later. So let's tie these things together. You've got to kind of think about how all these things are going on at the same time. So this is the chart that shows plasma levels of FSH and LH, okay, in correlation with what's going on in the ovary, all right? So you have the follicular phase, remember the follicular phase, all right, where you have your primary follicle becoming a secondary follicle, then a vesicular follicle. That vesicular follicle or mature follicle will then ovulate at day 14 and release that egg. The luteal phase is that time that you have your corpus luteum secreting progesterone and LSA. Yep. Progesterone and estrogen, sorry. So notice this huge increase in LH. That's the LH surge. So after the LH surge, you get ovulation. So the LH surge is responsible for that ovulation. This 14-day window is constant. Okay, this is so when we're talking about pregnancy later on, we're going to talk about how you can figure out when you're most likely to ovulate. You're going to count back from the day of your first period, okay, and count back 14 days. That's the day you ovulated. The follicular phase can be changeable. It's not necessarily constant, but the luteal phase should be a constant 14 days. All right, and that's the end of that lecture. So we'll move into the uterine phase. We're going to put these together, and then we're going to talk about pregnancy. Thank you very much.